Oh, got it. That is creepy, Whitney. Okay. So what I've put together is just a series of cases that we'll go through and sort of a case followed by an explanation. And hopefully this is board worthy. I threw in a couple of extras from Stallworth's board review when he did nephrology. So a couple of these may be familiar. But they'll hopefully run the gamut of everything nephrology. So the first case is an 11-year-old female who is admitted, has a history of severe asthma, and is found to be hyponatremic with a sodium of 130. The following day, it drops to 122. So astute resident gets plasma and urine osmolalities and a urine sodium. And the question then based on those is which of the following is the most likely cause of the hyponatremia? And one could think, well, asthma might be related to a particular cause. And I don't really know how to make this interactive, but I do have 3 people in front of me. So we'll get 3 guesses as to the answer. Is it diabetes insipidus, SIADH, hyponatremic dehydration, or drinking too much water? And I don't have a buzzer or a water balloon or anything. So you stand no chance of being demoralized by a wrong answer. So what do y'all think? Good. So remember that changes in serum sodium almost always reflect changes in water. And in this case, hyponatremia means you have excess free water. So you can be a psychogenic water drinker and drink your sodium down to low. There was a history of that. That's very unusual. And then the water excretion is always under the influence primarily of ADH. And remember that you've probably all heard me say this before, but if the pee don't match the blood, there's a problem at the kidney. Okay, it may not be a primary kidney problem, but urine should always match serum. So in this case, the patient's urine osmolality is inappropriately high for the hypoosmolar state, even though urine osmolality can go up to like 12 to 1400. So it should have been 100. So because of that, it is an ADH problem or SIADH. So an inappropriately high urine osmolality in the setting of hypoosmolality. All right, let's flip to the opposite side of that. A 15-year-old comatose patient has a sodium of 165. The rest of the labs you see there, UN 28 creatinine 1,1. In this case, the plasma osmolality is 345 and the urine osmolality is 80. All of the following are true except. So which one is not true? He could have central DI. He could have nephrogenic DI. The ADH level can be high, low, or normal. These labs are consistent with hypertonic saline administration. What you think? What's the mismatch in this one? Okay. Yeah, so correct. You don't know which one. And so kind of like our psychogenic water drinker situation, you can create hypernatremia with too much salt. Right, so the ADH level varies based on the type of DI, right? And so if you salt load yourself and get hypernatremia, you still should have, the urine should still be, so you shouldn't have that dilute urine. So what protects you against hypernatremia is ADH, the retained water, and your innate thirst mechanism. This patient's urine is very dilute inappropriately for the serum osmolality, indicating again that mismatch is an ADH issue. And central and nephrogenic DI have the same metabolic profile, but the level will vary. And it can be inappropriately normal. So in central DI, if it's total, it's going to be low. In nephrogenic DI, it's going to be high. but they're partial defects and it can be inappropriately normal. So remember looking at a lab in the context of the situation, kind of like a parathyroid hormone that's normal when it should be super high, et cetera. So this is the wrong answer would be hypertonic saline because of the osmolality mismatch there. And I didn't mention that second question, but I put this in just to give you a quick and dirty shortcut. If you wanted to calculate water deficit based on serum sodium in the setting of hypernatremia, there's two ways to do it. One a little more accurate than the other. You see the formula there, sodium measured divided by 145 minus 1 times that ever popular volume of distribution factor of 0.6 times the weight will give you the deficit in liters, or an easier to remember and somewhat accurate estimate would be about 4 cc's per kilo for every milliequivalent above 145. So just a couple of formulas there. All right, a 6-month-old breastfed baby comes in with a first-time seizure. Lab assessment shows a calcium of 6.2 with a normal albumin, phosphorus 3.8, electrolytes are otherwise normal. Which of the following tests would be diagnostic of nutritional vitamin D deficiency, which is suspected by the history? So don't make it too hard. So what lab test has to be low or abnormal if it's nutritional based on the sequence of activation of vitamin D?
25.
Ooh, did somebody say something?
25.
Yes, whoever said that, the 25 hydroxy D, right? So the elevated PTH is a normal response, right? If you have a low calcium and don't have an elevated PTH, then you're hypoparathyroidism. A low or inappropriately normal 125 occurs in kidney disease and a genetic form of vitamin D failure, which is a direct 1-alpha hydroxylase enzyme deficiency, one of the rickets syndromes. The alk phos being elevated just means bones being turned over by the elevated PTH. So when you work up hypocalcemia and get your D levels, if the 25D is low and you don't have liver disease, you're done. It's nutritional. There's just nothing else that can do that. So with the low 25D, it has to be nutritional. And of course, that fits the presentation of a breastfed baby and so forth. So yeah, 25D first, then the 1-alpha second, right? So it's kind of backwards, but you've got to have the nutritional D in its activation, and or you're going to get hypocalcemic just from that. All right, a 12-year-old female has isolated proteinuria detected on a routine physical. Her urine protein to creatinine ratios are in the morning 0.08 and in the evening 0.8. Orthostatic proteinuria, this is where you go, ooh, it's orthostatic proteinuria, and the next line is you suspect orthostatic proteinuria. So which of the following are true of this condition? Microhematuria may be present. There's a 5 to 7% chance of progressive renal disease. Total urine protein is typically less than or equal to 1 gram on a 24-hour urine, and the serum creatinine may be elevated. Very common. Those of you going into practice are going to see this many times a year. Yeah. Good. Isolated proteinuria is a lack of other findings. There's just nothing else. Trust your history, trust your physical, trust your normal blood pressure and the rest of the urine being normal. In a well kid, it's a completely benign condition. And there have been longitudinal follow-up studies with BOP, with benign orthostatic proteinuria, for 35 to 50 years. And they simply don't develop chronic kidney disease as long as the proteinuria remains orthostatic. So 5 to 7% chance is false. There's a 0% chance, basically. The literature will say you can have up to 1,500 milligrams or 1.5 grams per 24 hours, but most of us agree we get a little concerned if you're above 1 gram. So just remember that 1 gram per day. You may not even get to a 24-hour urine, and it's okay. You don't have to quantify it if that first morning urine is negative. So the amount was the answer. All right, an 8-year-old boy comes in for a routine physical without symptoms and has microscopic hematuria. And y'all, you confirm it with a UA. You don't trust the dipstick, you get the UA, and there's 10 to 20 red blood cells per high-powered field. This is isolated hematuria because everything else is completely normal. The family history is negative. Parents have had a checkup in the last year and had no blood in their urine. So with this isolated microscopic hematuria in an 8-year-old boy, the question is, what is the appropriate next test? A, renal ultrasound, B, complement levels, C, urine culture, D, urine calcium to creatinine ratio, or E, 24-hour urine for protein. Yes. So this is the hematuria counterpart to BOP, right? This isolated microscopic hematuria. And in the absence of symptoms or anything else going on, the likelihood of you missing kidney disease is very low. So you can be brave, again, trusting your history physical, the lack. Now remember, combination of hematuria and proteinuria is always abnormal and has to be pursued, but that means it would no longer be isolated. So the most common causes here are benign familial, benign idiopathic, and hypercalciuria. And benign idiopathic and benign familial may be the same condition. It's an autosomal dominant thinning of the GBM, but it has to start somewhere. So maybe the idiopathic is the first index case in the family, but it is very benign. So if you can attach that isolated label, then you do one test, a urine calcium, and you just follow them. Yes, so yeah, because if you have hypercalciuria, if you diagnose it, which is the most common diagnosable cause, then you will work that up. So a hypercalciuric kid will get a renal ultrasound and a one-time PIM panel. But the hematuria itself does not get that for you. So see in a year, yeah. No, unless there's symptoms like he passes a kidney stone in the interim or something like that. So it really, these two things, which are bread and butter nephrology, are generally very benign if you can attach that isolated label. All right, a 2-year-old male, everybody's favorite diagnosis. A 2-year-old male has hyperchloremic metabolic acidosis, okay? And you get urine electrolytes, there they are, urine sodium 50, potassium 20, chloride 90. So assuming this is RTA and not renal failure, I guess to give you a little help there, which of the following is the most likely based on the urine electrolytes? Distal RTA, proximal RTA, type 4 RTA. We'll throw out renal failure. And this is tough. I mean, this is, you have to kind of think about what that urine anion gap, the urine electrolytes. And the hint, how helpful it will be, I don't know, is that just like the osmolality match, the urine is electroneutral. So what is the urine anion gap with those numbers? Yeah, minus 20, right? So the anion chloride is 90, the cations add up to 70, so you've got a gap of a negative 20. Well, remember, your urine is not negatively charged, it's neutral. So if you had to bet, what is the unmeasured cation that makes up that 20 that's in the urine? Yeah. Acid, hydrogen, right? So if you have RTA and you are effectively eliminating acid, okay, what does that mean as far as the type? Good. So the urine gap is used to help you figure out the type. It's not 100%. It estimates the amount of whether hydrogen is present in the form of ammonium. A low GFR from renal failure and distal RTAs are associated with a positive gap. And it's proximal RTA and diarrhea that have the negative gap. Okay, so I'm acidotic and I'm peeing out hydrogen. Okay, then you've either missed the history of diarrhea or it's proximal. So if the gap were positive, conversely, that would suggest the absence of acid in the urine. And if you're acidotic and you're not peeing acid, then you must have distal or type 4, because those when you have those, you have impaired acid secretion. So just if they throw urine lights at you on a board exam, just slow your brain down and say, I just need to know, is it positive or negative? And then understand what that's telling you. And it's really telling you more about what you're not measuring. That makes sense.
Dr. Hallman,
Yeah.
to get a type 4, they would have to give you a serum potassium, correct?
Typically, is that Liz?
Yes.
Hey Liz, so typically the potassium can help you, but unfortunately the potassium can be normal in all 3 types. But if they do throw a potassium at you that's elevated, it's type 1 or type 4. If they throw a potassium at you that's low, it's type 2. But more often than not, and this is the case clinically, it'll be normal because of all the counter-regulatory mechanisms that can keep your potassium from being high or low. So the classic thing to file in your brain is type 4 hyperkalemia. You're absolutely right, but type 1 or distal can do it as well. And remember, type 4 is an aldosterone problem. So that's the cause of the hyperkalemia. You're resistant to it or you don't have it, so you can't pee it out. Okay, a 6-year-old with new onset nephrotic syndrome, you get a urine, you got 3+ protein, 20 to 30 red cells per high powered field, creatinine CBC complement levels are normal. Of the following, what is the most likely diagnosis? A, interstitial nephritis, B, FSGS or focal segmental glomerular sclerosis, C, minimal change disease, D, membranoproliferative glomerulonephritis, NPGN. Good, yes. So they're trying to trick you here by throwing hematuria at you, right? So about 90% of primary nephrotic syndromes in children are minimal change followed by FSGS. Interstitial nephritis is usually pyuria more than hematuria, okay? MPGN is a low complement renal disease, and complements in this case were normal. And the tricky part is remembering that, 20 to 25% of kids with minimal change disease can have microscopic hematuria. So they would want you to know that minimal change is far and away the most common cause of the nephrotic syndrome, even if there's some microscopic hematuria present. Now, when you see a kid like that presents classically and you think it's minimal change and you do find on your UA that there is hematuria like this case, you're going to do complement levels. Whereas nephrotic presenting at the right age with no hematuria would not require complement levels. Because if the complement level came back low, then you'd be in a whole different category. And if it comes back normal, you go back to presuming the child has minimal change and treat accordingly. FSGS is a little more likely to have hematuria, but remember at the onset, they're treated the same way. We don't biopsy them. And complements are normal, of course, with FSGS as well. So I think some of these I wrote, some of these I pulled. So this is one I pulled. And I think, again, they're trying to trick you by throwing that hematuria at you and try to throw you off your game of knowing that minimal change disease is the most common cause of the nephrotic syndrome. All right, a 3-week-old uncircumcised male presents with poor feeding and irritability. You get a urine, it shows 25 to 50 white cells per high powered field. And of course, you suspect urinary tract infection. So which of the following statements regarding UTI in this infant is correct? A, his risk for UTI would be the same if he was circumcised. B, the plan would include a clean bag urine sample for culture. C, if UTI is confirmed, he is at increased risk for vesicoureteral reflux. And D, the best test for confirmation of pyelonephritis in this case is a DMSA scan.
B.
What's that?
B. B.
B?
D as in dog.
We're saying B.
D. Okay, I know. Sorry, the sound is not great. So remember that, there's been a lot of pendulum swinging in the evidence-based medicine of urinary tract infection. It's come a long, long way in treatment and how we work it up and everything else. But circumcised males do have a lower incidence. So that kind of rules out the first one. Always try to avoid bag urines, and you guys know this. There's a very high false positive rate with bag urine cultures. We get a lot of calls from the community with kind of process of ruling out UTI in the office, and so if they don't want to cath the baby and the baby's not sick and they don't plan on treating empirically, you could start with a bag, and if it's negative, you're home free. But if you're planning to start antibiotics at the onset and then stop if the urine culture is negative, you might be caught with a contaminated bag urine culture. There is no question that an infant with a UTI has a higher incidence of VUR, okay? And remember that pyelo is a clinical diagnosis, and a DMSA scan has a lot of is not very sensitive or specific in an infant, even though it's all over the literature and it's a $4,000 test. So trust your judgment on age of the patient, how sick they are, presence or absence of fever, to determine whether you think it's an upper tract or lower tract infection. And the good news is, in a not sick kid with pyelo, it's pretty much oral therapy anymore. So, so the answer is actually C. So the second part. Yeah. So yeah. Oh, yeah. 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 No, it means that the likelihood that he has reflux is greater than if he had never presented with UTI. All right, a male infant is delivered at 37 weeks with a history of oligohydramnios, multiple dysmorphic features, including low set ears, flattened midface structures, wide spaced eyes, bilateral club feet. He is anuric and dies on day 3. Which of the following is the most likely cause of this baby's death? Gram-negative sepsis, congestive heart failure, pulmonary hypoplasia, renal failure, intraventricular hemorrhage. First, so what is this describing? Potters, okay. Page is correct. So oligohydramnios means you have intrauterine renal failure or obstruction. So your urine output is down or absent. And the consequence can be Potter sequence, which this baby has. Lots of causes from a renal perspective that fall in the CACET kind of umbrella, congenital anomalies of kidney and urinary tract, if it's a bilateral process or urethral obstruction. And the consequence is underdeveloped lungs or pulmonary hypoplasia. So can they get urosepsis? Sure. If they're volume overloaded, can they go into heart failure? Sure. Those are manageable. And the renal failure, I joke that we can now dialyze a turnip. So, I mean, we can put a PD catheter in and do dialysis on very, very small babies now. So the cause of death is typically the pulmonary hypoplasia. We have a baby in the NICU now that tricked us. So his posterior urethral valves and had prenatal bladder drainage done at Chapel Hill to try to take pressure off the kidneys. And so had a vesicostomy done or had suprapubic caps or catheters done prenatally, which is quite amazing that they can do that. Was born with what was thought to be horrible pulmonary hypoplasia, was on the oscillator for, 10 days or so, and now is on room air. So you just never know, but the pulmonary hypoplasia is what leads to the ethical discussion of whether we should intervene from a dialysis perspective. All right, as part of a diagnostic workup for hematuria, a renal biopsy in a 9-year-old male reveals IgA deposits in the mesangium. Which of the following statements about this patient is correct? Biopsy was indicated by documenting microhematuria on 3 occasions. End-stage renal disease is increased among Caucasians and younger patients with this condition. The presentation likely included episodes of intermittent painless gross hematuria. Patient will likely have an increased urine calcium to creatinine ratio. And finally, the patient will likely have low complement, C3 and CH50. So this is what disease? Yeah, I mean, there's only one disease that can give you IgA deposits in the mesangium, and that's IgA nephropathy, or HSP, which is IgA nephropathy. Yes, see? Good. So mesangial IgA deposits are hallmark for IgA nephropathy. It is a normocomplementemic renal disease. So remember, on board questions, they'll throw IgA in there at you as the exception, because I think it's a little tricky because you see IgA, you think immune system, you might go complement involved, but it's normal complement. So don't fall for that. This is not hypercalciuria if you have IgA nephropathy. And there are risk factors for progression. It is generally a pretty benign disease in kids. It's one of those rare diseases that if you diagnose it young, you do better than if you get diagnosed with it as an adult. But the risk factors for progression are proteinuria, hypertension, older age at biopsy, and African-American race. And then the typical presentation, remember, this is one of our 2 relatively common glomerular diseases. This one more common than the second one, that gives you that intermittent gross hematuria following routine viral illness. Parents of these kids just get very used to it. They'll get the sniffles and they'll go, I guess you're going to pee blood tomorrow. And unless something weird changes, they stop calling eventually. And that's okay because it's self-limited. We would never, I have never, most people would never biopsy a child with hematuria only. So the fact that this case got a biopsy means there was proteinuria. But intermittent painless gross hematuria, IgA nephropathy. What's the second one? What else can do it? In a male. Not in a female. Yeah, Megan, did you say? Alport syndrome, good. Parents of a 3-week-old male infant report seeing blood in the diaper. Oh my goodness, the baby had an uneventful term delivery, appears well as a normal blood pressure and physical exam. Urine is heme negative and there are no red cells present on micro. Which of the following is the most likely cause of the baby's findings? A, calcium oxalate crystals. B, UTI. C, hemoglobinuria. D, uric acid crystals. E, renal vein thrombosis. Yeah, you know this, right? Kind of freaks parents out. So the baby has discoloration in the diaper with heme negative urine and no cells. So hemoglobinuria, for example, or myoglobinuria would be heme positive urine. So this was a completely negative urine. Renal vein thrombosis, there's really no reason. There's no setup here, term baby, not a congenital nephrotic. But regardless of that, there are going to be more symptoms. You're going to have hematuria, hypertension. Calcium oxalate crystals, remember, may, but not always, because you'll see them in a benign setting, may represent hypercalciuria, and hypercalciuria causes hematuria. There is no hematuria here. So uric acid crystals is the right answer. Very common office thing that you'll see, of course. All right, a 5-year-old male presents with periorbital edema and parental concerns regarding not peeing as much. On exam, he has mild pitting edema. Blood pressure is 118/80. On a lab assessment, you've got an elevated BUN and creatinine at 52 and 2.8. Hemoglobin is 8.5. Platelets are 80. Based on your presumptive diagnosis, all of the following portend a poor prognosis except So this is going to be one of those board questions that you have to slow yourself down, reread, right? Because it's layers. So what is your presumptive diagnosis in this case? Because that has to be first. What goes against? Or what's I mean, yeah, you could say he's nephrotic because he's got edema. We haven't looked at a urine yet, but it's going to be abnormal. Yeah. And what should the hemoglobin be in a run-of-the-mill nephrotic or elevated from hemoconcentration? So now what's your presumptive diagnosis?
HUS.
HUS, okay? So based on the diagnosis of HUS, all of the following portend a poor prognosis except. What has a better prognosis? Classic E. coli OM57H7 diarrhea positive HUS or familial genetic atypical? Yeah. So okay. And the atypical forms tend.
Is the answer the white count?
Yes. So patient has HUS, classic triad of renal failure, anemia, thrombocytopenia. And if you have enough proteinuria and have a low albumin, you're going to have edema. Okay. Classic diarrhea positive HUS has a better long-term prognosis than the non-diarrheal forms. And it's a high white count that's associated with the poor course or prognosis. Sometimes they'll come in with just huge white counts. So the answer is A. All right, which of the following is least likely to be associated with sickle cell disease? Hematuria, proteinuria, UTI, hypertension. All right, so obviously it's not hematuria, right? That's a very common association. And the hallmark of sickle cell nephropathy is FSGS, or a version of FSGS, and that is a proteinuric disease. They have their immune system's not normal, right? So they can present with UTIs a little more than the general population. Remember, sickle cell patients run low blood pressures. And so when we see a high normal 90th to 95th percentile blood pressure in a sickle cell patient, that sticks out at us. So it's actually hypertension because they tend to run low. They hyperfilter, they run low creatinines and have low blood pressures as a baseline. Yeah, I guess if they have pretty advanced sickle cell nephropathy, if it is FSGS, then they can get some, yeah. Yeah. Newborn baby has a palpable left flank mass. Ultrasound reveals multiple cysts throughout the left kidney with a normal appearing right kidney. Blood pressure, labs, UA, normal. Parents are in their early 20s and are healthy. There is a history of some hypertension in grandparents. Of the following, which is the most likely diagnosis? A, autosomal dominant polycystic kidney disease. B, Wilms tumor. C, multicystic dysplastic kidney disease. D, autosomal recessive polycystic kidney disease. Shout it out. C, good. So remember, the polycystic kidney diseases are bilateral, and there can be some asymmetry, but both kidneys should be involved. So when you see a baby in practice that has, or maybe you know about it prenatally, that's the most common thing nowadays, that has a unilateral kidney finding, that should allow you to relax a little bit, okay? Especially if everything else is going according to plan. So Wilms tumor can occur very early, but usually is going to have hematuria or something else, more findings on ultrasound. And the most common, well, this is kind of old because nowadays we have prenatal ultrasound diagnosis before we feel that abdominal mass in the newborn nursery, but multicystic dysplastic kidney is the most common congenital renal anomaly. And we're thankful for that because it's a fairly benign unilateral abnormality. The kid's just going to go through life with one working kidney. They start out big. That's why you can often feel it on your abdominal exam. And then they involute over time and ultimately disappear. And the focus shifts to just being sure that the contralateral kidney is healthy and growing, showing compensatory hypertrophy, growing at an accelerated rate as it should as the one working kidney. So we'll stick with cysts. All of the following statements regarding ADPKD, autosomal dominant polycystic kidney disease in childhood are true, except A, approximately half of kids with ADPKD have an elevated creatinine by adulthood. B, in kids with a positive family history, the presence of one cyst is diagnostic. C, cysts may develop prenatally in dominant polycystic kidney disease. D, kids with ADPKD often present with hypertension. So which one is false? Guess. A, that's a good guess. Yeah, so ADPKD, remember, can present at any age. Remember, in the old days, dominant disease was referred to as adult polycystic kidney disease and recessive infantile, and that's been abandoned because the age of presentation is all over the place. We actually have about 3 or 4 families here that had prenatal cysts and a classic family history. So it's now described purely by its genetics and associated findings. Hypertension is known to occur, in fact, is pretty much the only complication in childhood of dominant polycystic kidney disease. Because of the genetics and the rarity of simple acquired cysts in kids, that happens in the adult world with some frequency. If you have a classic family history and you ultrasound the kid and there's one cyst, it's practically diagnostic that they've inherited the gene and will have it. No, we discourage it. So, you know, until there's a time where there's genetic treatment for this condition, by screening kids of parents, you're just setting them up for insurance issues and being labeled as having a chronic kidney disease. And as long as they're getting good regular care, have normal blood pressure, they, especially knowing that they typically maintain normal renal function well into adulthood. Remember, in the worst form of ADPKD, you develop advanced chronic kidney disease in your 50s to 60s. So it is inevitable, but it's late. So you really don't have to, we don't screen labs in our pediatric population with ADPKD, but we do often have to treat their blood pressure. So increased creatinine in childhood is not likely. I need to hurry. A 3-year-old presents to the ED with a history of diarrhea and vomiting and looks moderately dehydrated. Blood pressure is normal. Lab assessment is as you see it there, BUN 42, creatinine 1.9, sodium is up to 146. UA shows a specific gravity of 1.008 with 1+ protein, no blood or white cells. The urine sodium is 60. No hydronephrosis is seen on ultrasound. Of the following, which is the most likely cause of this child's renal failure? A, pre-renal, B, intrinsic renal, C, post-renal, and D, renal vein thrombosis. Yeah, you can talk about them. Except like we said, that you have hypertension and hematuria, and this child doesn't. So that leaves you with what? Yeah. So the purpose of this one is to remind you that as you transition from that pre-renal injury, which your BU and creatinine can be fairly impressive, into intrinsic renal, you lose renal tubular function. Okay. So when you're dehydrated, even with a pre-renal insult to the kidneys, you still have intact tubular function. So you're responding appropriately to dehydration. You're retaining sodium. You're holding on to water. So your spec grav is high, your urine sodium is low. There isn't a normal one, is the unfortunate thing. But if you're pre-renal, it should be less than 20. Yeah. And so when you lose your ability to concentrate and you lose your ability to retain sodium to help keep you hydrated, then you've entered into tubular injury and intrinsic disease. So pay attention to those clues with the urine, which will help you know where you are in that spectrum. So again, renal vein thrombosis, you should have hematuria and hypertension. You've ruled out obstruction with the ultrasound. And just as we talked about, intact versus non-intact tubular, renal tubular function. 9-year-old with chronic kidney disease secondary to renal dysplasia has developed bad bones, renal osteodystrophy or metabolic bone disease or chronic kidney disease, which can be attributed to all of the following except. So which one does not contribute to bone disease? And this is just pay attention to words, right? So as GFR declines, what happens to your 1-alpha hydroxylase mechanism? Your ability to activate vitamin D, it goes down. And as a consequence of not having enough D, you due to what? So what? That's exactly right. But what is the immediate effect of not enough D? Just like our baby earlier with the nutritional D. Hypocalcemia. So if you just know that, you've ruled out 2 of them. And what does phosphorus do with advanced CKD? You can't pee it out. Yeah. Now, if you were going, Dalton, with PTH promoting pee out the phos, but the GFR is such that the kidney ain't listening. Okay. So again, look at the words. What is PTH in chronic kidney disease?
Shouldn't it be hyperparathyroid?
Exactly. So as you gloss through this, it gets a little confusing, but if you just remember that PTH is elevated in CKD, and this is hypoparathyroidism, then that'll get you to the answer. So again, as GFR declines, your phos goes up. You can't 1-alpha your D. Both of those, either through hypocalcemia in the case of D or directly in the case of a high phos, promote PTH secretion, and it's kind of unbridled. So PTH doesn't care where it gets the calcium from. It's going to pull it out of bone. And if you don't treat that, then you're in this constant state of bone demineralization. The metabolic acidosis people forget about. Remember, if you have acidosis, which certainly with chronic kidney disease you can have, part of how your body adapts to that is bone buffering. So bone releases mineral to buffer the acid, and that promotes more bone disease. So in this case, it was just recognizing that it was the wrong word that they threw at you. secondary hypoparathyroidism is wrong. All right, a 14-year-old male presents after passing his first kidney stone. His exam is normal. He has the following labs: sodium 140, potassium 3.8, chloride 116, bicarb 14, creatinine 0.8. Here comes our urine chemistries again: sodium 40, potassium 38, chloride 75. Calcium creatinine ratio is a little elevated at 0.6, and the urine pH is 6.5. Remember, calcium creatinine ratio, like protein creatinine ratio, 0.2 is the upper limit of normal. So treatment should focus on all of the following except: A, low sodium diet; B, bicarbonate therapy; C, thiazide diuretic; D, low calcium diet; and E, potassium citrate therapy. And this is another one of those questions that's layers. So you kind of would back up and say, well, what is my diagnosis here? It definitely is hypercalciuria, but what else, Dalton? Yeah, I mean, based on those, yeah. Right. And then you'd say, okay, well, which RTA is associated with hypercalciuria? Because only one of them is.
Type 2.
Type 1. So distal RTA goes with calcium. Okay. So which of the listed therapies would you not implement? And I'm not saying you would implement all these. Well, you would implement most of them, but which one would you not? And while you're thinking about that, back to the urine anion gap per our discussion earlier, in this case, the cations are higher than the chloride. So your gap is positive, implying the absence of acid. And in this, yeah. Yeah, you know, it depends. So do thiazide diuretics increase or decrease urine calcium? The opposite of Lasix. Does Lasix increase or decrease urine calcium? You know, remember all those NICU babies that get nephrocalcinosis? Well, Lasix causes it. Yeah, yeah. So potentially the thiazide diuretic could be used to lower the urine calcium. Now, in all honesty, we wouldn't start with that. We'd start with diet. And remember, I always say in nephrology, if you had to guess a diet that's true, or that you would want to implement, you would always pick low sodium, right? You just you want to treat the acidosis? Yeah, so bicarb therapy seems reasonable. And potassium citrate actually prevents kidney stones, so that might be reasonable. So we don't restrict dietary calcium. That's the point of this one, is even if you're hypercalciuric, it has nothing. All right, so a hyperchloremic normal gap metabolic acidosis with a positive urine anion gap is most likely secondary to distal RTA, which is associated with calcium issues, hypercalciuria, stones, nephrocalcinosis. We treat hypercalciuria 100% of the time with a low sodium diet, because the more salt you eat, the more calcium you eat. So they are linked in the distal tubule, where, by the way, thiazide diuretics work. So a thiazide diuretic is a prescription medicinal way to accomplish what a low sodium diet accomplishes, okay? So we always start with diet, and we're gonna get the bicarb corrected, of course. And in a stone former, you might be a low citrate excreter. Remember, citrate is anti-stone. And so you might implement some supplementation with potassium citrate. And we never want kids below the RDA for calcium because it's important for their bone health. All right, a healthy 8-year-old is found to have isolated microscopic hematuria on a routine physical. His father also has hematuria. Benign familial hematuria is suspected. All of the following are true except, which one is false? Proteinuria is not associated with benign familial hematuria. Inheritance is autosomal recessive. Biopsy findings may be indistinguishable from Alport syndrome, and end-stage renal disease does not occur. Which one is false? Well, aren't all questions tricks? It might look like Alport syndrome because there's thinning of the glomerular basement membrane, and there's not a lot of findings with Alport syndrome on biopsy.
B.
Yes. Remember, benign familial hematuria is autosomal dominant. Okay. You should not. Yeah. Yes, and there, in fairness, may be more findings with Alport syndrome because what they can do now is stain for the collagen that's absent. So it's the inheritance. A 15-year-old girl presents for a routine physical with blood pressure 140/92 without symptoms on multiple readings. She has a history of a febrile UTI at the age of 2. On lab assessment, she has normal blood work, and her urine shows 2+ protein with 10 red cells per high-powered field. The test most likely to identify the underlying etiology of her hypertension is A, DMSA scan, B, echo, C, renal ultrasound, D, renin level. I feel bad about this question because I tend to poo-poo this test with y'all a lot, but in this case, well, yeah. So as y'all know, the most common cause of hypertension in school-age kids is far and away essential disease. Renal parenchymal disease is still the most common cause of secondary hypertension, but I mean, you're talking in a school-age kid, that's 10, 15%. So the history of pyelo and the abnormal urine suggests renal scarring. And the best way to detect renal scarring is with a DMSA scan, okay? Now, I don't want you thinking that every girl that shows up with hypertension that has a history of a UTI and a mildly abnormal urine gets a DMSA scan. So, but that is a scenario where it would be the most helpful because it's more sensitive at showing parenchymal scarring than a renal ultrasound. You're going to get the ultrasound first, the cheaper, easier test. But you can miss a scar with ultrasound, and renin levels, in theory, this is renin mediated hypertension. That's what renal scarring, that's why renal scarring causes hypertension. But renin levels are notoriously misleading and inaccurate. Well, it's the kind of thing, Don, that's like where there's smoke, there's fire. So if you had one, could you have had more? And that, you went in with that fever and you were 18 months old and you're screaming and had a red ear and got slapped on amoxicillin and what just got treated was the UTI. Yeah. And that's not being judgmental. That's just the reality of what happened. Yeah. The real clinical decision would be, do we need confirmation of a scar with a story that's compelling, or can we just put them on an ACE inhibitor anyway? And if their blood pressure is normalized and they're doing great and had a normal ultrasound, we save $4,000. But again, DMSA scanning is all throughout the literature, so it's finding its way into testing. So that's why I include to the board testing. So that's why I included it, so you know its principal utility. A 7-year-old girl is admitted with coke-colored urine and hypertension. She had a URI a couple of weeks ago. She has periorbital edema, impressive hypertension, creatinine of 1.2, C3 of 20. normals above 80, too numerous to count red cells with red cell casts on a UA, meaning she didn't come to this institution, and 3+ protein. The most likely diagnosis is A, Goodpasture syndrome, B, IgA nephropathy, C, post-infectious glomerulonephritis, D, lupus, or E, Wegener granulomatosis. Yep, you said Paige. C. So Goodpasture syndrome or anti-GBM disease Goodpasture must be associated with pulmonary hemorrhage. That's why I get it. That's the syndrome of Goodpasture. And remember, when complement is low, it narrows your differential to 3 things: post-infectious, lupus, and the MPGN spectrum of disease. We just had a girl in the hospital, a week or so ago, who's probably going to have C3 glomerulopathy, had a C3 that was undetectable. No systemic symptoms of lupus in this particular case, and the age is very atypical, but lupus would have been in the differential. And just playing the odds, y'all know, post-infectious, far and away in kids, the most common cause of the acute nephritic syndrome, which we're fortunate because it's the most benign version to have. Complement is key. Soon after birth, the term infant developed severe respiratory distress. Prenatal ultrasound showed markedly enlarged kidneys that were diffusely echogenic. Autosomal recessive polycystic kidney disease is suspected. The most common associated finding with AR-PKD is cerebral aneurysms, hepatic fibrosis, pancreatic cysts, cardiac valve anomalies, and kidney stones. And this is just association, right? There's associated findings with recessive and associated findings with dominant, and it's just remembering which go with which. What goes with recessive? That's dominant. Got another guess? Good. So dominant disease is associated with cysts in other organs, cerebral aneurysms, and the classic sites are liver, pancreas, and ovaries, kidney stones, and heart valve abnormalities. The one they'll mention is mitral valve prolapse, has a higher incidence in AD, PKD. Recessive disease is the bad liver, okay? So periportal hepatic fibrosis that down the road leads to horrible portal hypertension, esophageal varices, and so it can be a hot mess. And we're thankful that recessive disease, by virtue of its name, is extremely rare because it's much worse for kids than dominant.
So the cyst in the liver and dominant disease, like the liver function is still normal?
Yes.
Okay.
Yes. So just, yeah, cysts in other organs is a very commonly tested association. Yeah. Recessive disease doesn't give you cysts anywhere else. And they can start showing up on ultrasound, but they're usually microscopic at the beginning, so that thus the echogenic kidneys that are big. All right, almost done. 5-year-old boy with nephrotic syndrome is admitted with anasarca. His initial UA was negative for blood. His blood pressure was 90/60, and his creatinine is normal. He's treated with albumin and Lasix, and after losing 2 liters of fluid, develops gross hematuria with abdominal pain and hypertension. Of the following, the most likely diagnosis is A, acute glomerulonephritis, B, acute tubular necrosis, C, hemorrhagic cystitis, D, interstitial nephritis, or E, renal vein thrombosis. I know, we finally got a renal vein thrombosis.
Yeah.
All right, so remember the nephrotic condition can be associated with ATN from hypovolemia, but this wouldn't explain the hematuria or the hypertension. Interstitial nephritis is also not associated with gross hematuria and hypertension. The timing is all wrong for acute GN. Nephrotic syndrome is associated with thrombotic potential. And if you overzealously, by accident, dry them out too much, you promote more thrombotic potential. And so this is why we don't just slap every relapsed nephrotic in the hospital to get some cosmetic edema off of them, because it is not without risk. So it's renal vein thrombosis. And I think this is the last one, guys. 9-month-old presents with growth failure and apparent polyuria, polydipsia. Mom says just soaks through diapers and is constantly cranking and wanting cranky and wanting the bottle. Blood pressure is normal. Lab show creatinine of 0.2, sodium 133, potassium 3, chloride 114, CO2 14, glucose normal, phosphorus 2. The urine has glucosuria, proteinuria, and a spec grab of 1010. Of the following, the most appropriate test to determine the etiology of the child's condition is A, ADH level, B, white cell cysteine level, C, plasma renin, D, serum magnesium, or E, slit lamp examination. So again, this is the layered question. What's that?
B.
B is correct. So you have to back up and kind of figure out what this is telling you diagnostically, right? So if you have glucosuria, proteinuria, and a normal anion gap metabolic acidosis, i.e. RTA, what is that? What is that constellation of findings? It's not just an RTA, it's Stalwart's favorite thing, it's Fanconi, right? So then you have to say, well, what are the causes of Fanconi syndrome? And Liz shouting out B is that cystinosis is definitely a known cause of Fanconi syndrome and something we can test for. So the hyponatremia may have taken you down an SIADH pathway, but that wouldn't explain any of the other findings that are there. Increased renin results in a low K, but blood pressure in this baby was normal, and hyperreninemia or hyperaldosteronism should make you alkalotic, not acidotic. So the constellation of findings support Fanconi tubulopathy, and cystinosis is one of the more common causes of secondary Fanconi. And it is confirmed by measuring leukocyte or white blood cell cysteine level. Oh no, 9:08. Sorry, I went late. All right. Good, you're all gonna ace your boards in the renal section.
Thank you.
All right, guys.